I'm just going to touch on this just really quickly from a radiologist's viewpoint, and these things have already been alluded to. But I wanted to just touch on one or two things from a European perspective. We know that the incidence of renal cancer is increasing both in the USA and Europe, and the thing everyone trots out, and it's all because we're all imaging and picking up lots of incidental disease. But in fact, when you look at the statistics, thanks very much, I'm a radiologist, I like to do everything in the dark, so otherwise it kills my slides. So in fact, when you look at the crux statistics, the actual mortality from renal carcinoma is actually increasing. Importantly, certainly in the UK data. And some people have argued this is some sort of just elderly bulge of disease that's working its way out of the system with imaging techniques that we've really developed, let's be honest, in the last 25 years or so. But undoubtedly the mortality attributable to renal cancer is increasing. And that's possibly attributable to hypertension, obesity, and the fact that we're all living longer and not dying so quickly of cardiovascular disease. Another sort of given, or things that people trot out, the tumour growth rates are often meaned out at about 2.6, 3 millimetres per year in the Chawla paper. But of course, you and I all know that there's a huge range of behaviours. 20 to 30% are completely indolent and stable, as Mike was saying. 20% will be much higher risk and will grow faster, regardless of their size at presentation. And we also know, as we've heard earlier on from Kevin Harris, that some 30 to 40% of patients will have demonstrable or unexpected chronic renal disease at the time of their disease presentation, and also that there's patients who have normal creatinines who've got occult kidney disease. I won't take it any further than that, Dr. Harris, but it's a complex debate. And we also know here, as we also heard earlier from the GO NEGM series, that renal function is an important predictor of your expected overall longevity and your risk of cerebrovascular and cardiovascular disease. Now, the problem is all this small 4-centimetre disease that's out there. We've heard already that the expected outcome in terms of cancer-specific survival is perfectly good with a partial or a lap partial, if you're good enough to do it. But also, small, focal, rounded disease, which kidney cancer is, certainly in the T1A disease, is currently ideally suited to ablative technologies. They really do work. That's actually their scope of function. And we also know that CT, MR, and ultrasound are able to localize in any plane, not just looking at something on FAST, but this is a radiologist. We talk now in terms of volumetric data and looking at things in all 3 dimensions orthogonally or as volumes and not as slices. And that's something, as a radiologist, we've learned over the last 10 to 15 years to get away from just slice analysis. Laparoscopy undoubtedly gives you a very vivid view, and I'm at some risk here, I know, but it's inherently an en face appreciation of what is in fact a volumetric 3D problem. So the question is, can ablative technologies be deployed safely and importantly effectively, not just knocking a hole in something, but effectively in the abdomen? There's 3 sort of areas I want you to think about this. One is the devices, and the companies have been working very hard, and there's a whole host, you're going to hear about some of them, of devices out there. Image guidance, this is the sort of forgotten aspect of this. Very superficially, you can hold an ultrasound in front of a sphere and roughly stick something in, but it is striking to me as a radiologist that I then simultaneously CT scan that patient, and in fact I'm completely off in a whole 2 other planes, and my probe, which I thought was at the center of that sphere, is absolutely not at the center of that sphere. And when we get to looking at effective outcomes from ablation, we've really, in engineering terms, got to be looking at tolerances of placement of 3 to 4 millimeters if we're going to start getting really good outcomes from these ablative technologies. And then I'm going to talk about sort of treatment completion, dosimetry, and adjunctive techniques to really make sure that we are ablating that entire disease. So what about radiofrequency ablation? This is the one I suppose you'll be expecting me to talk about. Now, I've been fiddling with it in Vancouver since 1994, doing pig work and what have you, and undoubtedly it was a major step forward. The problem that many people don't realize is that, in fact, by sort of flipping these little water molecules, that actual zone of active heating around the monopolar tines is actually only within a few millimeters of the probe tip itself, the uninsulated probe antenna. So you're actually actively heating there, and then you're hoping that the heat is going to disseminate out. And the end result is that you're heavily reliant on conductive heating more than 3 millimeters away either side of the probe tip itself. And the end result is the manufacturers have had to do all sorts of tricks, clustering the probes together, making them expandable, to try and get more effective spheres of treatment. But let's not beat around the bush. You can get a sphere, if you work away at it, for 3 to 4 centimeters in diameter of 100% cell kill. But there is a nasty trailing edge with RFA, which has been its Achilles heel for some time. Microwave, I'm just going to briefly mention this, and one point of interest to something. I do a lot of microwave in the liver and the lung because I think it's effective. But I don't microwave in the kidney. It has the same dosimetry problems. There's a very boring word. You've got to be able to dial up these technologies and say, we will achieve this volume of ablation and it will be relatively defined and controlled. And microwave suffers in the same way as RF does from this sort of gas obscuration of the target. It works basically as a single radiating antenna, much like your domestic microwave at home, by sort of wobbling the water molecules around and heating them all up. But interestingly, I pulled out a microwave probe one day to buzz a sort of a little tumour of about 18 millimetres on the lower pole of a chap's kidney. And we hadn't got our dosimetry, I think, fully worked out, the amount of energy we need to deposit to achieve a sphere of treatment. And we treated this for about 6 to 7 minutes of microwave at about 180 watts. Nice result, but I ended up knocking a hole in his perfectly healthy pelvic ileal system, which I haven't seen in dozens and dozens of cryoablations. And then, interestingly, about 3 months later, his whole kidney dropped on a sort of a split function to about 12%. And we were talking about warm ischemia, but just warming, I think, diffusely warming a kidney does not do it any good at all. And that's about us working out the dosimetry of these techniques. How much energy do we need to achieve the appropriate outcome? We've reported that case, by the way. It's sitting in print, or waiting to go to print. This is another technique, electroporation, they've been using in the lab to perforate cells so they can transfect them with sort of plasmids and what have you in cell cultures for some time. But in fact, if you just turn it on for milliseconds more, you can permanently or irreversibly electroporate the cells. And I think this is causing a lot of interest, this technique. It's still got to go through some treat and resect studies, and it still requires the placement of multiple antennae in a sort of a configuration. But it's quite interesting. But the reason I like cryoablation, and I know Frank's going to talk about it as well, is that importantly, and I'm repeating that word dosimetry, we can see the ice beautifully with current imaging techniques. So unlike that gas obscuration I got with RF and microwave, here with ice we can actually sit and watch, and I'll show you some pictures in a minute, the ice evolve minute by minute on a CT scan, as you know, with ultrasound, and even more elegantly perhaps with MR. It does appear to have a relatively tight margin, not that ill-defined margin we saw with the RF, and perhaps a little bit more of a bell-shaped isothermic sort of map to it, rather than that sort of Eiger Matterhorn configuration we saw with RF. Certainly we aim to treat by more than 5 millimeters over the edge, but I won't say anything more than that. It's interesting, though, that my practice has moved in the last 3 years. I've stopped RFing kidney tumours and we cryoablate them over the last 3.5 years. The other sort of spin-off benefit we've seen is that the cryoablated tumours appear to involute much more quickly than the RF ablated tumours past the cell injury. Image guidance is absolutely critical to this. Here you can see, I've said I think these probes need to be placed with 3 and 4 millimeter tolerances if you're placing in sort of multiple constellations of cryoprobes to be really accurate about what you're achieving. And certainly it's been borne out sort of image guided over, dare I say this, laparoscopic guidance in terms of efficacy, cost and transfusion requirements. This is our setup in the lab here, and you can see I use a combination of ultrasound and CT to place the probes. There's all sorts of things going on with image guidance, you know, sort of electronic Navi guides and things like that. Let's just see if this video wants to work. This is another technique. I've tried this quite a few times, where we take the volumetric CT data and you put it in and you toggle it to the ultrasound data, so you can hold an ultrasound probe and look through the CT data simultaneously in 3D space. So it's projecting for you. You're sort of cutting through that CT data set, so you're getting a simultaneous CT and ultrasound image here in the liver. I have to say, you've got to be very careful of these things. There's a whole load of information, electronic information, coming at you. And this machine has this green circle that appears, and it tells you you're on the money. But if you've not got those data sets absolutely toggled in space, it's like a Bluetooth technology, then it can be very misleading, and it can mislead your brain as the operator. Oh, that's going to do for it now. I'll shut that down. So let's go to treatment completion and how we ensure that we've got a full treatment. Certainly with RF on analysis, we found that we could treat up to about 35 millimeters perfectly, respectively. And polarity, upper pole tumors are not difficult with image-guided ablation, or I believe AP location. You can see for years now I've used hydrodissection with 5% dextrose. We now contrast stain it to actually push the bowel out of the way, and we can get very adequate treatments. Now, I promised Tim this is only a minute and a half, this video, and it just shows you a really straightforward treatment of a polar tumour. We look carefully, we put these patients in. Now, I do all my procedures under general anaesthesia with combined CT and ultrasound guidance, and you can see here we prone oblique the patients, and we've done hundreds of patients in the CT scanner like this, and I've got a very good supportive anaesthetist. Here we're cryoing. I don't need to show you this because you're perfectly familiar with cryo, but we prone oblique the patients, take a lot of time placing the probes, as I say, plus or minus 3 millimeters. You can see here dissecting the sort of colon out the way. The reason for doing that is you might say, well, hold on, there's enough of a space there. But in fact, I want to get lots of space like you do laparoscopically, so I've got it completely out the way, and then I can really aggressively treat and make sure that the ice is overlapping fully and fundamentally that tumour. There's too many people, I think, sort of get coy with that. You can see here planning, there's the dissection fluid in there, and we're planning exactly the distance from the edge of the tumour of the cryoprobes in 3D space, not from one angle. And there you can just about see the ice evolving to subsume the tumour. I don't know if you can make it out in this light, which gives us nice dosimetry for the procedure. And that's the room setup. So I just wanted to quickly show you that. Now the data, well, we all know in these sort of lower grade tumours it's problematic, isn't it? It's classical cancer study outcome markers of 5-year overall survival and progression-free survival are very difficult to power up to make observations between different treatment techniques. We know certainly that the analysis is fundamentally compromised by non-randomized retrospective data collection and very horrible, intractable mixtures of RF done percutaneously versus laparoscopic cryo and what have you. So to tease stuff out, much as I know David Kunkel et al. Have tried to do, is quite difficult. And another thing that I think is a bit naughty sometimes in some of the big meta-analysis, they just say, oh, we'll lump it all together and we'll call it local tumour progression. And I make a major distinction between when I know I've subtotally treated something on follow-up imaging and going to a completion treatment, and we do that in about 6% of our cryo cases, and ones where there's late local recurrence. That's a major distinction that is often not made in some of these big crashing meta-analyses. What about the data? Very quickly, RF ablation, well, we could be very criticised for not following up ourselves. Here's a group, this is NYU, Steve Solomon, and they followed up here 30 tumours post-RFA out to 5 years. Disease-free survival, 90%, cancer-specific survival, 100. But they did notice late local recurrences following RF at 7, 13, and 31 months. Ron Zagoria's group here, 125 tumours, 100% tumour-free survival. Again, that important treatment threshold for RF of 37 millimetres. Tumour position was not a statistically significant issue. And recently they've done a sort of a 5-year outcome analysis of 48 tumours in 41 patients. 10 died from other causes. No recurrences in the sub-4 centimetre group. Just ourselves here with RF, we published this in 2007, again 37 millimeter treatment threshold, and in fact we've had 5 late local recurrences. This is course data where we've really struggled to follow them all up. 5 late local recurrences at 10 to 51 months. So there is a small but undoubted 3 to 5% late local recurrence. What about our RF complications? Well, the complication rate in that almost 250 treated cases was 3.2%. One full-thickness PUJ injury here, where unfortunately I fried the PUJ. And then here in another case where I biopsied first, obscuring hematoma like we were talking about earlier on, and then I went to do the RF and, of course, perforated the duodenum because you couldn't accurately see. But a pretty low complication rate. What about the percutaneous cryoablation? Well, the Bill Charbonneau's group at the Mayo Clinic here reporting a few years ago now 115 tumours in 110 patients. That was 2008. No late local recurrence at a mean follow-up of 13 months, and no problem with tumours that were anterior and even in their greater than 4 centimetre group. Our own Southampton data, last 2 slides. 130 procedures, this is a very recent analysis we've done, 139 tumours in 118 patients with a mean tumour size of 31 millimetres. We had a complete ablation rate of 97.8%, and in the remaining outstanding 3, the MDT one, I wasn't there, said, oh, we won't bother retreating. We had a 6.6% subtotal treatment rate who went on those 9 patients to go to completion treatment. Biopsy yields, as we'd expect, 70% RCC, 18% ONCs, and then a mixture in here. And 97 of 137 procedures just incurred a single overnight stay. And the ones who required more than an overnight stay were almost always decatheterization problems. So our complication rate in this series is 4.6%. That's Clavien Dindo greater than 2. 1 embo, 1 2-unit transfusion, 1 chest drain, 3 temporary ureteric stents. AP location was not an issue. There was a slightly higher subtotal treatment rate in the group greater than 4 centimetres in diameter. And to date, we've had a single late local recurrence at a mean radiologic follow-up of 13 months and a mean clinical follow-up of 19 months. Imaging follow-up's important. We're using CT, but we're also in patients with more impaired EGFRs using subtraction MR and getting perfectly good results. But there's a lot happening in this area in radiology, automated sort of segmentation software where you can look at the ablation zone and plot it very, very accurately against the previous original treated tumour. Perfusion. I think diffusion-weighted imaging is going to be highly complex, but perfusion imaging is looking very promising. Just a little slide I've tucked in, Mike, on active surveillance. I'm just going to put some counterpoints here. There is a morbidity and a cost to radiologic surveillance. I'm a radiologist, I get to do it. So every 3, 6 months or 12 months, it does cost and it does take time and money. We all know that 3 to 4 centimetre disease does contain high-grade disease in about 14 to 25% of cases. There's no way of anticipating that. Lack of growth does not indicate benignity. And interestingly, from my reading, 75% of tumours grow under active surveillance, so you have to keep on going a bit for a while. And a very large proportion will and can cross over into resection. Now, we know that may be patient pressure and all sorts of things, but it's an important rate of crossover. Prediction of growth rate is not truly possible to predict their growth rate, and volumetric growth rate's even more problematic. A 2 centimetre sphere, to double its volume, importantly, only has to put on 5 millimetres. A 3 centimetre sphere only has to put on just over 7 millimetres, 8 millimetres, to actually double its volume from an oncological perspective. And I think, and I'm being a bit naughty here, but a lot of this active surveillance is predicated on the morbidity of the procedure you're about to deploy. So effective ablation brings a new treatment paradigm to the table. So in summary, I think cryo's overtaken RF. I think it's optimally applied with volumetric image guidance. Ablation, like surgery, it requires diligent technique. It's not just a question of putting the probe in and cooking it. So there's all sorts of things that improve outcome from a sort of an image guidance perspective. There's a lot of compromised literature out there by retrospection and case selection. I think post-treatment biopsy, which the Cleveland Clinic has advocated, 6-month follow-up, is I'm a radiologist, and again, I'm deeply biased, but it's also flawed as a technique. It only tells you about the scruffy little bit of tissue that you get from one aspect of that treated tumour, and that's all it's telling you about. And there's highly problematic interpretation of that post-ablation histology. There are costs and morbidity associated with active surveillance, and I think ablation brings something new to the table. Thank you.